Hello and welcome to Taking Care of Cancer from the Clatterbridge Cancer Centre NHS Foundation Trust. And this time we're going to talk about treatment, and we're going to hear the perspectives of a patient, of an oncologist and of a specialist nurse. And before we start, we'd like to have a round of introductions, please. Shall we start with you, Chris?
Yeah, sure, thank you. So my name's Chris Knight. I got diagnosed with stage 3 bowel cancer in October last year. I finished chemotherapy a couple of weeks ago, so I'm now waiting for surgery.
Okay, thank you.
I'm Rachael Gregory. I'm the ward manager of the chemotherapy day unit at our Liverpool site. Patients attend for chemotherapy for the day and then they go home again as an outpatient.
And you can tell us all about what that's like. Thank you.
I'm Rick Walshaw. I'm a consultant clinical oncologist at Clatterbridge. I treat patients with bladder cancer and prostate cancer using different types of treatment, including radiotherapy, chemotherapy, immunotherapy, and others. So thank you for having me.
That's okay. So we'll be exploring all the different types of treatments that are possible now for patients with cancer. But before we do, we're going to hear one particular story, and that's your story, Chris. Can you tell us about your journey? I mean, how it started and what position you were in at the time you found out?
So I was 38 when I found out. Kind of started to have symptoms in the summer. A little bit of pain, a little bit of blood. And then kind of with a busy lifestyle, it was very much on and off. So 1 week it would be fine, I'd feel fine. And then I started to get a bit more tired. Symptoms became a bit more regular. Went in to see the GP, straight away sent off for some tests, and then in for a colonoscopy within a couple of weeks. And then the diagnosis happened literally during in the colonoscopy. I think the guy doing it, David Bowden, was quite shocked. He kind of wasn't expecting what he saw, so I could tell that reaction. So he told me straight away, and very much a life-changing moment at that point. But then kind of a couple of weeks to gather yourself, I guess, because for me it was a complete shock. You know, relatively fit, don't smoke, live a fairly active lifestyle, so you kind of don't think, it's never you, right? And then kind of got through a couple of consultancy appointments, started with the surgeon, and then across to a consultant, and then in for chemotherapy. Probably started in November from memory, and I had 4 rounds of treatment, which, as I said, I've just finished about 10 days ago, a couple of weeks ago. And it was way less bad than I thought it was going to be. And the nurses were amazing. So.
Oh, that's good. Yeah, that's a nice message. Now, this has all been very recent and very sudden, as you say. You first started feeling symptoms at the age of 38, that's right, isn't it?
Yeah.
Last May?
Probably start of the summer. Yeah, difficult to pinpoint, but yeah, definitely start of the summer.
And you said you went to the GP, but there was a gap, wasn't there? You didn't go straight to the GP.
No, absolutely. Kind of, I wouldn't say I put it off, but as I say, the symptoms were on and off. And I was like, they weren't that bad, okay? So I was kind of like, oh, this will pass. Like, is it just IBS? What is it? And eventually the symptoms got worse. And my girlfriend at the time, now wife, was like, you're going. So she definitely encouraged me to go.
Good for her. And she's not your girlfriend, as you say, she's your wife now.
Yeah.
So did you get married more quickly?
Yeah, definitely. It was on the cards, but the diagnosis gives you a new perspective on life. So we went for it pretty much straight away. Actually got married in 5 days.
You mean you booked it then?
Yeah. Proposed and got married in about 5 days. So, yeah.
Amazing. So tell us a little bit more about your treatment. You could unpick that a little bit.
Yeah, so I hope I get the names of the drugs right, but one's oxaliplatin, which is delivered by infusion, and then the other was, you'll have to tell me the name of the...
Capecitabine?
Yes, that one, thank you, where you take tablets. So essentially, I had 4 3-week cycles, which were infusion on day 1, then you start taking the tablets immediately, and from there, you have 14 days on the tablets, then a week off, and then you kind of go again. Very, very scary the first time around, as I'm sure you'll have experienced patients, a bit kind of rabbit in the headlights. And it was definitely not as bad as I thought. I probably had 2 or 3 days where I felt really, truly terrible. But that was actually because I picked up a cold, got an ear infection. That got worse because obviously you've got no no immune system really. That was on the third one, but yeah, if I could tell someone who was in my position, whatever it was, 3, 4, 5 months ago, it would be, it's not going to be as bad as you think it will be. Well, certainly the case for me, because hearing the words chemotherapy, you're like, so.
Well, yes, we'll find out from Rachel a bit more about that, about how it works and how different people react to it, and how I know that you make it as comfortable an experience as possible.
Yeah.
But just going back to the treatments and the decisions about treatments, Rick, how do you decide how you're going to treat a patient and who's involved in those decisions?
So we operate throughout the NHS, to be honest, using what's called an MDT, so multidisciplinary team. And when patients are first diagnosed, and indeed sometimes as they go through their journey, we discuss them within our MDT meeting. And this is usually oncologists like me, the surgeons who've diagnosed them, other doctors, physicians potentially, clinical nurse specialists who know the patients, and radiologists, pathologists. So they're the people that look at the scans and the people who look at the cancer samples under the microscope. And we bring all of that information together within the MDT meeting and decide what is likely to be the best treatment for the patient. And that depends on many different factors. Obviously, what type of cancer it is, the organ of origin of the cancer, where the cancer, if it has spread to, and other things which are more specific to the patient. So, are they relatively fit? Can we use quite significant, tough treatment, as it were? Or are they not able to tolerate that? Do we need to do more gentle treatment? And once we have all of that information together, one of us, sometimes more than one of us, meets the patient and discusses it with them and outlines what we're planning to do and tells them what it's likely to involve.
And there are many more treatments. There are many more treatments now, aren't there, than there used to be?
Yeah, certainly. So over the last 10 or 20 years, there's been an exponential growth really in different treatments that we can now give. 20, 30 years ago, treatment was very much chemotherapy, if that, and perhaps radiotherapy. But over the last couple of decades, we've become a lot better at really understanding what makes cancer tick. And actually, not all, so for instance, Chris has colorectal cancer. Not all colorectal cancers are the same. They have different, what we call mutational drivers, different things that make them work. And as we've learned more and more about how these cancers are functioning and what drives them, we can target treatments a lot more specifically these days to go after that type of cancer rather than just, using very blunt tools such as chemotherapy. Now, there is still a very important role for chemotherapy and it can be a very effective treatment. But I think over the last few years, we've developed these, we call it personalized therapy, more targeted therapy, which goes after individual types of cancer. And I think that's only going to improve and become more and more over the next few years. The other thing that we've learned to do over the last few years is stimulate the body's own immune system to fight the cancer. So some of your listeners may have heard of immunotherapy. And I've not probably put that very well, but that's essentially how immunotherapy works. It stimulates the body's immune system to go and find the cancer cells wherever they are in the body and hopefully attack them and shrink the tumour or, and make the patient feel better. And again, 20 years ago when that wasn't on the horizon, even people didn't know about it. But certainly it's come to the fore over the past 10 years or so. Melanoma, a type of skin cancer, was probably the first type of cancer where we started using this treatment. And in some patients, it's very, very successful. So again, immunotherapy, I think, is going to continue to evolve over the next few years and hopefully really benefit patients.
That's great. We are hearing about some of these advances in research and innovation in other episodes of Taking Care of Cancer. Rachel, when a patient comes in for chemotherapy, and you're the manager in charge of that unit where they come in on a daily basis, what's the environment like? What would Chris expect when he came into your unit for the first time?
I think we first meet a patient in pre-assessment and it's not on the chemotherapy floor, it's down in -3. And we explain how they may find it when they come, and we try and say, it's a comfortable environment, everybody's smiling, and probably not what you'd expect the environment to feel like. And when they come, they do say, oh, you were right. So when we first take them from the waiting room, we bring them in, weigh them, and we take them in to be seated. They get a drink, and we have a little chat, and then we assess them. All of that is, it's very, I'd probably say quite laid back. And then if they raise that they've not been feeling well, if they've had a toxicity from treatment, we talk through that, and explain what we're going to do to support them through that.
What's it like when you first go in for treatment? It must be quite daunting the first time, Chris.
Yeah, it definitely is. As you said, the nurses are amazing at putting you at ease. So my experience was on the Clatterbridge, on the Wirral, on that unit. And the first time I went in for that initial consultancy was very much, you're still rabbit in headlights, like, oh my God, what's happening? But then actually being shown round the chemotherapy unit kind of puts you at ease. And everyone there is super friendly. And as you said, it's a weirdly relaxed environment for what you're going in for. So I definitely had a laugh with a lot of the nurses, and which was great. And I think, I was probably one of the younger ones on receiving chemotherapy. So for me, it was really important to try and lift everyone else's spirits as well.
You were the joker in the group, were you?
Pretty much, yeah.
I'm sure every ward needs one. And Rachel, what do you see when you go in? As Chris said, it's very calm, it's very relaxed. So people sitting there reading, doing their knitting, what's going on?
So we encourage them to bring whatever it is that they want to be comfortable. We have patients that have cool cap treatment as well. So they're quite cold. We encourage them to bring blankets. So the cool cap is to prevent hair loss. So they can bring literally whatever they want to be comfortable through that. But people bring iPads, books, people play games. They bring whatever it is that they want to make them feel comfortable during that time. Some of them are there for the day. So they'll bring little wheelie suitcases full of different things, which is fine. We encourage that, whatever keeps them at ease and makes them comfortable.
But it's all different, isn't it? So when you went in, Chris, it wasn't for a day, was it, at a time?
No, so my treatment lasted about 2 hours. So it was kind of a 3-hour slot, because you have what they call a flush, which is to make sure the line's gone in okay.
Yeah.
I think that's right. And then they give you a flush at the end as well. So it was kind of like 3 hours for me. You were in and out. And as I say, that bit was very much the scary bit, actually going in, getting the IV put in your arm. I was terrible. I fainted the first time. But after that, you kind of get used to it. And yeah, as I said, it's a much more calm, and I wouldn't call it enjoyable, but the environment is incredible considering what everyone's going through.
Chris, I know that some of my patients who've had chemotherapy have made friends with other patients on the chemotherapy unit, and they tell me about this in clinic, and I always find it quite nice. And then they stay in touch with each other, after their treatment's finished. Have you seen any of that?
Yeah, definitely. I think the people who are in more regularly than I was, so I was in every 3 weeks, and then my toxicity levels weren't quite right, so I had a couple of weeks break. But I can definitely see that, you see friendships forming in other patients, and I had some great chats with some people who were there, having a similar treatment to me, for sure.
We actually have 2 ladies in Liverpool who they have treatment on the same day, and they sit next to each other in the bay. We've managed to coordinate that. They've been coming to us for 5 years now. So it's really nice, actually, and it's really nice for other patients to see that they form that friendship from it.
Yeah, that's great. Best buddies.
It's actually, I think it's an important part. It's not for everyone, and I can only reflect really on my patients, but peer support. So speaking to other patients who've had or are having or have had similar treatment to you, a lot of the patients I see in clinic have, outside of the chemotherapy unit as well, there's various peer support groups and things, and the patients that engage with that on the whole find it very useful, being able to talk to other patients with similar treatment or similar experiences, that's an important part of the support network for them.
I would second that. I think, speaking to someone who's been through something similar, there's nothing better. It's great speaking to yourself who's clearly an expert, but actually talking to someone about it. And for me, it was about hearing success stories, because being relatively young, you just kind of go, oh, am I going to be okay? What's going to happen? And hearing success stories is massively important for your mental health, massively.
Rick, after treatment of chemotherapy, presumably there's reassessment going on all the time. At that point, do you reassess, and then how do you make decisions from then on?
So That rather depends on what we're trying to achieve with the treatment that we're giving to the patient. Now, a lot of the time we're giving chemotherapy maybe after surgery or radiotherapy, or even before surgery or radiotherapy, to try and increase the chance of cure, years down the line, and stop the cancer coming back. And from what I led to believe, that's why you're having your...
Yeah, that's exactly right. So initially when I was diagnosed, the surgeon, because when you first get diagnosed, the cancer isn't staged. They then take a biopsy and try and stage it from that, as I understand it. So because mine was perhaps more advanced than they thought in the first instance, David, the surgeon who did the colonoscopy, very much thought he'd be doing surgery in the next 2 or 3 weeks. So one, that was why I got married so quickly. But two, that very much changed. You mentioned the MDT earlier, and I think everyone discussed it and said, in Chris's instance, because he's relatively young, what we want to try and do is buy him as much time as possible. And that meant chemo first in my instance.
Okay, yeah. So if you have the surgery in Chris's case, then sounds like that's what we call radical treatment, which is intent to cure. Doesn't always mean we do, but that's the intent of the surgery. And so the chemotherapy beforehand is what we call neoadjuvant chemotherapy. If he'd had that chemotherapy afterwards, that would be adjuvant chemotherapy. And the aim of that is to, like I said, increase the chance of cure eventually. Now, a lot of patients have a form of adjuvant treatment like that. Some patients, however, have what we call palliative treatment. And we know that in these patients, the chemotherapy is not going to cure the cancer, but will hopefully shrink it down, control it, reduce the symptoms, make the patients feel better, and hopefully make them live longer. And that's called palliative treatment. So what happens after each course of treatment really depends on what the aim of the treatment is. You're absolutely right in that we regularly assess the patients during their treatment, and the chemotherapy staff, are a really important part of that, because they will flag up very early if they're worried that the patient's struggling with the treatment. And then sometimes we have to change our plans. And that can be anything from reducing the dose of the treatment to stopping it and changing to something else. But we do scans in most cancer sites as well quite regularly during the treatment, especially in patients who are having palliative treatment, because what we don't want to do is give them chemotherapy or other treatment if it's not actually working and they get the side effects, but it doesn't affect the cancer, because in those situations, we know we need to change to a different type of treatment. So I appreciate that's probably a long answer, Caroline. I'm sorry, but it really depends on what the aim of the treatment is. Invariably, in someone like Chris, hopefully, we'll never see him again. He'll go off and live a very long life, happily married, hopefully.
Yeah,
and but in other patients, we give them some chemotherapy. They might have a break for a bit, and then we start another type of treatment depending on what their scans show.
And in your case, Chris, as we've heard, you've been having chemotherapy so that when you now have reduced the chances of needing surgery?
No,
what have
I
you been
think
told about that?
in my instance, it's pretty likely I'll need surgery. It would be a bit of a miracle case if that didn't happen, which is fine. That's due kind of middle of March, end of March. For me, when I started chemotherapy, it was very much with the goal of when will I find out if it's worked. And in my instance, there's no scans along the way. You basically have your scans at the start, which are, really part of diagnosing the disease. And then I had my scans pretty much on the last day. I took tablets, actually. So, as quickly as possible. And then I've got a meeting with Dr. Shawcross, who's my consultant, on Thursday to find out. So, fingers crossed.
That's a big day for you.
Yeah.
Well, fingers crossed.
Thanks.
And the role of nurses, of course, you're with patients like Chris all the way, aren't you, from when they're diagnosed all the way through whatever their treatment is involved, your role. So what kind of situations do you find yourself more valuable than at other times, for instance? When would someone like Chris need you most?
I think when patients are deferred for a week, if they've been unwell or their blood counts are low, it's about helping them to understand how that will impact the treatment plan, because people think if they put it off for a week that the cancer may grow or it will have detrimental effects. So it's about understanding that the body needs to be well to have that treatment. Although, we don't want to make people poorly.
I'd second that. So I had, over Christmas, my toxicity levels weren't right. So they have to be within a certain range, certain things.
Yeah.
And if they're outside of that, that then has to be referred to the consultant to kind of give the green light. Because it was Christmas and everything else, I had 2 weeks off. And then, interestingly, I picked up a bit of a cold from my lad on the Monday, and I was due in from treatment on the Thursday. And it was kind of like the cold was okay. And because I hadn't had treatment for 2 weeks, I kind of didn't say that much about it, had treatment, and then got really, really ill. So I would definitely say to any patients going through it that you are better to be really honest with the nursing staff, because they've only got the best interests at heart. And although delaying treatment for a week feels like a huge amount, actually it probably doesn't have that much effect from what I found out.
Can I third that? Is that the right term?
Yeah.
I think it's a question that my patients ask me and they worry about, in that if they're deferring their treatment a week or two, is that going to be detrimental to the overall outcome after their treatment? Now, the vast majority of the time, it absolutely won't be. And it's much better that they have a week or two off to recover, and then they can carry on with their treatment and maybe have several more weeks or months worth of treatment, rather than go ahead with it, get really unwell, and then we can't give them any more treatment for 2 or 3 months. So, I'd certainly echo what
I definitely got away with it, I'd say, because I basically got a head cold, got an ear infection, that then turned into a bone infection. So I was kind of throwing antibiotics at it and everything, but fortunately I kind of fought it off. But yeah, I think, as you said, you just got to be really honest with how you're feeling and what's got to be in tune with your body, which was definitely been a learning curve and something I'm still trying to work on.
I think something else we should probably bring up at this stage is the triage line, or the helpline that we have for all patients on treatment. I'm sure Rachael probably knows a lot more than I do, but it's available to all patients who are having treatment, and it's a 24-hour service. It's staffed 24 hours a day. And some of my patients, they don't like to bother people. And I always encourage them, look, I know you don't like to bother people, but it's really important that you contact the helpline if you're worried about anything. And that doesn't just mean if you've got a temperature or signs of infection. It's any side effect that you're worried about. You need to ring this helpline. And what I actually say to them is, if you're sat at home trying to decide whether or not you should ring the helpline, that means you should ring the helpline or triage line. So, Rachael, I'm sure you agree, it's a really important service.
Yeah, and it's something we educate patients on at the pre-assessment. But some patients will come, it'll have been the weekend and they won't have rang triage, and then they come to the unit and they're really unwell. So we really try and educate people to say, please don't sit at home feeling unwell. Please contact the triage line.
And it's super easy. Like I rang up once when I was poorly, and the answer super quick. And then I went to the GP. He sorted antibiotics, and then I was kind of on the road to recovery.
Great, that's a really good message.
And the other beneficial thing from my point of view is that the triage line let me know if they have any interactions with any of my patients, and so I can then suss out what's going on and look at it from my point of view and contact the patient back if necessary. So it's a really good system, really important.
It's not just about being poorly, is it? Presumably, because your psychological health, your mental health is so important. And imagine moments like you mentioned, having treatment deferred for a week, but there must be other triggers that
for some it's just about coming for the treatment overall. So when we're assessing it, we're not just assessing the toxicities, we are also having a chat and checking on them and their well-being, and checking that people have got support at home. And some people just do want to have a chat, and that's really nice, the nice side of the job for us, that we can make sure that people are okay with the well-being as well.
Have you found that, Chris?
Yeah, absolutely. The nurses were amazing, and I can't thank them enough. They like you said, it is the mental well-being that's so important, because you can be feeling okay, but actually it's such a worrying time. And for me, certainly as my treatment's gone on, the symptoms have started to clear up, which has just meant that the physical side isn't there, so you don't think about it 24/7. I have 4, 5, 6, 7 hours in there, nearly a day now, where I don't even think about it. And, you commented, it doesn't look like I'm poorly from the outside. And I've kind of been very lucky with the treatment so far. But that I think almost makes it harder for the patient, because people don't know what you're going through.
Yeah, definitely. I think, and that's what other patients have said as well. that's why it's good for us as the nurses, because we understand and we see it all the time. So that's where they get the support with the well-being.
And each other, the buddy.
Yeah,
Yeah, really good. It's also important that patients are as well as they can be before they undergo treatment, isn't it? So we're going to hear now from somebody about what we call prehabilitation. And that's consultant oncologist Dr. Rachael Brooker, who we've been talking to at Clatterbridge Cancer Centre, Liverpool, earlier today.
So patients go through such a difficult time when they're having their cancer treatment. It's really intensive. It's really horrible for them. It's horrible for their families to see them unwell. And to think that we had that opportunity to address any other medical problems that they had and to reduce the chance of them being admitted during those treatments, reduce their side effects, reduce the impact that has on them and their families is really important to me. It's important for their whole journey to make sure that they're able to cope in the future with living with the impact cancer has on them and to be able to recover well after their treatment as well. So addressing these needs before we even start can mean that later down the line that jump to getting back to some kind of normality is lessened for them. I think that's really important. So each patient's an individual. Everything has to be tailored to everybody's own needs. I think that's really important. Generic advice I give to patients is kind of touches on lots of different themes. The first one being their diet. So I ask people to try and eat the rainbow, make sure their plate is really colourful, and try and have as much protein as they can as well, because it helps with their muscles to heal after they have radiotherapy and chemotherapy, increasing the healthy fats they have. So lots of seeds and nuts and things like that can help as well. I always say to them before they start treatment, because lots of the things, the treatments I give, so the radiotherapy can mean that their mouth is quite sore. The chemotherapy can make them very fatigued and tired. So halfway through treatment, often they don't eat as well as they should do, and they don't feel like making a meal. So before they start, I ask them to kind of get a blender and try and make soft foods and put them in the freezer, so that if they have a bad day, they can just pop it in the microwave and be able to have something quick and easy, but also nutritious for them. In terms of their physical exercise, it's really hard to think about exercising when you're given such bad news. But we know it does help with patients recovering from their treatments and stop them being admitted during and mean their recovery's better. And simple things you can do, just walking more than you sit through the day, having a diary of what you're doing day by day and try and increase that week on week. Even 10 minutes of doing something extra can help. So if you know somebody with a dog or you like to go out for walks, meet with a friend and go for an extra walk, go up the stairs a few times during the day, put on your favourite song and have a little dance if you can with your friends and your family, and that will make you feel better as well and improve your well-being. Another really important thing is addressing any addictions you might have. So if you smoke or drink alcohol, there's so much support out there for patients who struggle with that, and signposting them to those services is something I really am keen to do each time I meet them.
Thank you, Rachael. Chris, going back to your story, you're also on a clinical trial, aren't you, with a certain sort of therapy? Can you describe what that is?
That's right. So essentially, one of the side effects of oxaliplatin is what's called neuropathy, which is, in my simple terms, it's basically really bad pins and needles, and it tends to be in the extremities of your body. So I've experienced it in my nose, in my eyes, but I've been really fortunate that, as you mentioned, this clinical trial, and what it involves is putting your hands and feet into really just a cool set of gloves and a cool foot mitt. And I think that's at 15 degrees they keep it cool to, but I don't quite understand the science behind it. But what I do know is the side effects that I've had, certainly my hands and feet, have been limited. And we were chatting before we came kind of on air or whatever you want to call this. And in my final treatment, where they put the line in, they couldn't close the cool glove. And what that meant is, essentially, I had the cool gloves and feet on 3 out of the 4 potential bits. And after the treatment, I had neuropathy in the hand that I didn't have the glove on. So, I can definitely say it works.
Sounds so simple as a treatment as well, doesn't it? There's a very painful side effect.
Yeah, so peripheral neuropathy, as Chris has very eloquently described, can be a significant problem for many patients. It doesn't happen with all types of chemotherapy, but there's certain chemotherapy agents where it can be notorious. So oxaliplatin, which is what Chris has had, paclitaxel is another drug that can cause it, and cisplatin as well, amongst others. And it can be a big problem, and it's a side effect that unfortunately sometimes when it happens, it doesn't actually get better, and it can be there long term for a small group of patients, and very unpleasant for them. And when that happens, at the moment, we have a few tablets and things, sort of painkillers that we can try to help with it, but they're not particularly successful. So stopping the problem happening in the first place seems the logical thing to try. So there's a type of therapy called hyalotherapy that we've just started using in a feasibility study at Clatterbridge on the Wirral to see if it can help. And this has been around in Europe for the past couple of years or so, and they're trying it in patients who are having chemotherapy like Chris, and they've had some really encouraging results. So we got in touch with the company that manufactured the machines, and they've lent us these machines for a few months so that we can see if we can deliver this on our chemotherapy units. And so far, it's looking really good. What we don't know is how effective it's going to be in the long run, but we're really encouraged by data that we've seen from Europe on that. And it's great to hear that Chris, has had a good experience with it as well. To put it in a nutshell, the way it works is that, like Chris says, we cool the hands and feet slightly, and that constricts the blood vessels in your feet and in your hands. And that stops the same amount of chemotherapy getting to those areas of your body, or this is how we think it works. And so you don't have as much chemotherapy getting to the nerve endings and damaging the nerve endings, and so that reduces the chance of getting the side effect in the long run. So fingers crossed, this is we'll show that we can deliver this, and hopefully buy some of these devices over the next few months so that we can deliver this treatment to lots more patients on these chemotherapy drugs.
Things are changing, improving all the time, aren't they? Just briefly, could you summarise where we're going with treatments and how they've changed and improved over the last couple of decades, maybe?
Yeah, so treatment over the past 20 years ago, it's all about damaging the DNA in cancer cells. So cancer tumours or lumps or whatever you want to call them are essentially big balls of millions and billions of tiny little cancer cells. And at the heart of each of those cancer cells, you have DNA, which is the instruction manual, as it were, for each cell, tells it what to do. And treatments have always been about damaging the DNA. So when those little cells have to reproduce themselves, they can't, because their DNA is not intact, and they die, and the cancer shrinks, and hopefully the patient gets better. But over the last 10 to 20 years, therapies have shifted to be a lot more personalized, depending on what's driving the cancer. So each little cancer cell has to tell it what to do. And so that can work in various different ways and can be driven by things like mutations that people may have heard of. And so we're now designing lots more drugs which go after those mutations, and therefore they're much more likely to work for that, the patient, if they've got that type of mutation. So we're going to see many more of those drugs coming out over the next, few years, and hopefully controlling cancer better in the long run. And the other thing is immunotherapy. Chris and I were talking about this before as well, stimulating the body's immune system to go after the cancer cells. And that can be very effective, but unfortunately at the moment, it's only effective in a relatively small proportion of patients, certainly less than half. But what we do know is that when patients respond to these drugs, and this is patients potentially with cancer that's spread elsewhere, they can respond for many years. And some people, immunotherapy can cure them. And that's really exciting. But like I said, it's only a relatively small proportion who have these really good responses. So as you'll hear in further episodes, we're now trying to improve this by combining immunotherapy with other types of drugs and medicines, which will hopefully improve those response rates. So more and more patients are benefiting from immunotherapy.
It's good to hear those notes of optimism for the future.
Yeah, absolutely.
Things are changing and innovation happening all the time. We have to leave it there now, but should we have a final word from each of you? So if you're going to give a message to anyone who has cancer, or anyone caring for someone who has cancer, about to go through treatment, going through treatment, what might that be?
I'll go, shall I?
Yeah.
So I think for me, obviously telling friends and family about it, everyone was pretty shocked. But one silver lining in it is a really good friend of mine was having similar symptoms. So he went and got checked out, went for a colonoscopy, and they found it at the precancerous stage. He's literally just had the op, I think last week, and that seems to have gone really well. So he said to me, look, Chris, if you hadn't told me, I wouldn't have gone. So for me, it's if you are feeling unwell or anything that just triggers something that you think, oh, maybe I should get that checked out, go get it checked out. Speaking from someone who probably waited 2 or 3 months too long, definitely go straight away.
Let's hope that people listening, there might be somebody listening who also goes and takes your advice.
Yeah, let's hope so.
I think from my point of view, this is the most daunting time in a person's life, and we are there to support every step of the way. And everyone, like Chris has said, everyone says that how comfortable the atmosphere is, and we're here to help every step of the way.
Kind of, I think it's worth saying that when you've had cancer, you join this weird club, and it's like how much work the nurses do, the consultants do, and it you don't get exposed to that unless you've had it really, or are really close to someone that's had it.
And you're going to meet a nurse like Rachael, so,
Yeah.
It's all like you, Rachael. You're in great hands. And Rick, what would be your final word?
Can I have 2 final words?
Yeah, why not?
So my first final word is I'd very much echo what Chris said, and the rule really for cancer, there are some exceptions, but the rule is the earlier you're diagnosed, the more chance of having a better outcome you have. And so I'd really encourage people, if they're worried about symptoms and things, please do go and see someone about it. Don't worry that you're bothering people. It's really important to get checked out. And the second thing is treatment now. The treatments we have available right across the board are better than they ever have been. And we are as good. We're fantastic at treating lots of different types of cancer now with really advanced treatments. And that's only going to keep improving over the next few years. The more and more we learn about cancer, the more and more research that's done. So, over the next few years, even with people that've got incurable cancer, hopefully we can make them live for many years, and at the same time they have a really good quality of life as well.
Thank you. And we'll have to leave it there. But thank you so much, Rick Walshaw, Chris Knight, Rachael Gregory.
Thank you.